morning, everybody. Can everybody hear me well at the back? Yeah, thanks. Thank you, Tim, for inviting me and putting this fantastic conference. You know, we see about 300 registrants at the meeting, and as Tim had said, this purely a fantastic representation from across the globe. So the topic I was given was the global cancer burden and implications for care for us as the perioperative clinicians. Because this is awarded a CME, I have to say that I have no particular financial disclosures pertaining to this talk. However, I am a consultant to Pacira and Medtronic and Merck Pharmaceuticals on their strategies to improve long-term outcomes with our perioperative care. So what I hope to do over the next 20 minutes is talk about cancer tsunami, which Tim has alluded to a little bit, and the societal burden it's going to place on all of us, whether we are citizens or we are healthcare delivery personnel. Perioperative strategies to influence outcomes, past, present, and the future. And finally, how we together can advance this field and, as Tim had said, add to the momentum that has already built over the last couple of years. Having some difficulty advancing the slide. Can I have the next slide, please? So if you really look at the GlobalCan report, which was published in 2008, it's a common belief that the cancer is a disease of the developed world. And if you look at the incidence, you can see the higher rate in Australia, New Zealand, North America, Western Europe, Southern Europe, and Eastern Europe. So pretty much a disease of the developed world. Next slide, please. Yeah, I'm clicking this, but it's okay. So right now, it's estimated that 1 in 3 of all people in the Western world will hear the word "you have cancer" in our lifetime. But more importantly, about 11% of all people who have cancer, after undergoing primary therapies, will have a recurrence. And about 22% of all people would have a second primary in their lifetime. So this is not just a disease where you get a diagnosis, you undergo therapies, and you're cured. We may control the cancer burden in that particular patient, but there is always the risk that it is going to recur. Fast forward 4 years to the 2012 GlobalCan report, and which now estimates that from 2008 to 2012, in the intervening 4 years, the incidence of cancer has increased 12%. And the primary reason for that is the changing demographics. Life expectancy, fortunately, is increasing all across the globe. And this is just a depiction of what we are seeing in the US. And I have no reasons to believe why it's not in the rest of the developed world. So from a pyramidal shape demographics, we are changing to a rectangular shape wherein a sizable percentage of the population are living longer. And we know that age is the single most important risk factor for cancer. But this increase in the incidence and the changing in the demographics is being seen also in the developing world. So in this cartoon here, if you can see that at least in the developed world, by about 2006 or so, you've seen that the population over 60 has overtaken the population in the 12 to 24 years range. But in the developing world, this inflection has started right about the same time, and you can see an exponential rise in the percentage of population who are living over 60 years of age. That's a good thing. But if you think from the cancer point of view, every 10 years increments in your age doubles the risk for cancer. So while we are leading more productive, purposeful quality of life, we are also posing ourselves to the increased risk of cancer. But in addition to advancing age, the other factors that influence the incidence of cancer are smoking, our behavioral factors, our obsession with caloric intake, the battle of the bulge, so to speak, and the inflammatory burden, whether it's due to the environmental factors, the daily stresses of living, the pollutants in our environment. All of these cause genotoxic stress. So in the simplistic terms, our cells in the body fail to do the reparative process during the cell division, and so there is a transformation to a normal cell, to a transformed cell, to a cancerous cell, and then it takes on its own course. But if you look at cancer-specific mortality, at least in the developed world, right about the 90s, there has been a decrease in the cancer mortality, both sexes, and that's continuing on that downward trajectory. So that's good news. Furthermore, if you look at the changes in the 5-year survival between the 70s, 80s, and 2000s, pretty much in all of the cancers, there has been a substantial increase in the 5-year survival rate. So while the incidence of cancer is increasing, our strategies with prevention, education, early screening, therapies is showing its benefit. In the US, when we compared the number of lives saved between 90s and 2010s, so in the last 20 years, with all the strategies that I have just mentioned, we were able to save about 1.6 million lives. So we're, I wouldn't say winning the battle, we're controlling the battle, at least in the developed world. So what this does is it has changed cancer from a terminal illness to one of disease of chronic burden. I think it's stuck for some reason. There you go. Again, this is the US numbers, but again, this can be said pretty much of the developed world. In 2012, with all these strategies, we have about 13.7 million cancer survivors in the US. 2/3 of them with a diagnosis of cancer live for more than 5 years. 15% live for more than 20 years. And 45% of cancer survivors are over the age of 70. As I've said earlier, but this brings on a different set of challenges, which is recurrence, new primaries, and the ongoing cancer care programs that are very costly and cost intensive. So if you look, at least in the US, the cost of cancer for 5 major diagnoses at the initial phase, at the continuing phase of care, and the last year of life. And this lightly shaded area is for 2010, and the darker area is 2020. So if you add up the costs, how much we spend in these 3 phases of care for all these 5 cancers in 2010 and compare it to 2020, there has been a 22% increase in the cost of care. So we have a situation in the developed world where the mortality rates from cancer are coming down, life expectancy is increasing, but it brings on a different set of challenges in terms of recurrence, second primaries, ongoing care, and the cost. But if you go to the developing world, it's a different set of challenge. There is a wide variety of incidences, causes, morbidity, and mortality. But more importantly, if you've seen the Lancet Commission on Global Surgery, and particularly global cancer surgery, what they've said is there is still a problem with providing safe surgical and anesthetic care in the developing world. And not investing appropriately in safe surgery and anesthetic care in the developed world would lead to about $180 billion with a B dollars in 2015 numbers. And if we continue on that track, and if we project it out to 2030, the cumulative cost in terms of GDP is about $6 trillion. So there is a dire need for us to not only invest in safe perioperative care strategies, but also particularly in the realm of cancer care. So if you add all this up, the total cost of cancer care delivery, both in the developed world and the developing world, far outweighs the next big problem, which is cardiovascular and cerebrovascular diseases. So this is something we will be faced with in the future. So the next part of my talk today is going to be, is this patient population, the patient with a diagnosis of cancer, at a higher risk for perioperative morbidity and mortality? So this is a paper from Terry Monk and her group, which was published in 2005. They looked at a prospective observational study of about 1,000 patients who underwent all kinds of non-cardiac surgery. And then they looked at the entire continuum of the perioperative care and what are the factors which influence morbidity and mortality. And what they found was for all comers, the 30-day mortality was about 0.7%, and the 1-year mortality was about 5%. But if you happen to be a patient who is elderly, that's over 65 years of age, again remember, this is the high-risk patient for cancer, your mortality doubles at both 30 days and at 1 year. So if you're over 65 years of age, and if you're in the US, 1 in 10 will be dead in a year. This is all comers for non-cardiac surgery. And about 50% of all of these patients have a diagnosis of cancer. So the point I want to make is that a patient with a diagnosis of cancer is definitely at a higher risk for both 30-day and 1-year mortality compared to a patient who is undergoing major non-cardiac surgery. Then the question becomes, if the patient is at a higher risk, is there anything we can do to improve outcomes for our patient? And as Tim had already alluded to, while there have been earlier publications in the 90s which have looked at the associations between anesthetic techniques and outcomes, mainly in patients with melanoma, it's the work from Donald's group which has catapulted this idea into the mainstream. And that certainly has generated an interest amongst most in this audience and the speakers today on what can we do. And what this group found was women who were having breast cancer surgery with paravertebral block and a propofol anesthetic compared to a volatile anesthetic and an opioid-based technique had a hazard ratio for recurrence out until 3 years lowered by about 5 times. So this was a phenomenal association that has really generated a lot of interest. However, when similar retrospective single-center studies were conducted, there are about 18 to 19 publications to date, and they were not able to replicate the same findings in all kinds of cancer. So I'm not saying that doing a regional block with a propofol has definitely proved to improve outcomes. We've definitely seen there is an association, and it generated a lot of interest. And the hypothesis by this landmark study was that by providing adequate analgesia and opioid-sparing strategies, are we able to modulate the immune responses to a positive outcome situation? To date, like I've said, there are a lot of retrospective trials, but we are still waiting results from 3 prospective randomized controlled trials which are being conducted on a multi-center basis with breast, colorectal, and thoracic surgery. So if perioperative immune modulation by regional anesthesia and opioid sparing could benefit recurrence-free survival, we need more than an effective regional block. That is important for improving outcomes, but if you're looking at cancer-specific outcomes, we have to look at every other factor that influences perioperative outcomes. And here, these are all the factors that mediate the perioperative cancer outcomes. First and foremost is the tumor biology. Why are certain tumors with the same histological type are more aggressive in certain patients than the others? How about the effect of tissue injury on circulating tumor cells, the growth factors? Obviously, afferent neural blockade and endocrine and metabolic stress is important. Injury-mediated inflammation, immune suppression. But still, there are a lot of other biological factors which we're beginning to understand. As you can see, the benefits of the regional block are part and parcel of this comprehensive system that influences outcomes. Now, moving away from regional block, our researchers have looked at perhaps looking at other strategies where you can change the balance of the immune suppression and inflammation. And the studies are being conducted with beta blockers, non-steroidal anti-inflammatory drugs, the combination, IV local anesthetics. And our friends from Royal Marsden have published that if patients undergoing cancer surgery have TIVA compared to a volatile-based anesthetic, for all comers, even after they were adjusted for ASA status and the metastatic grade, patients who were given a volatile anesthetic had an overall 50% increased hazard ratio for recurrence and overall survival up to about 3 years. So there is a lot of research, ideas, interest amongst the spectrum of people, right from basic scientists, translational researchers, and clinicians, to see if indeed what we do can influence outcomes. So where is the money? As of today, while there is a lot of interest, it's very unlikely that a single intervention is going to make an impactful difference to long-term outcomes. So we need a comprehensive perioperative approach, and that's because our cancer patients are different. Like I mentioned earlier, if a patient for a hip replacement comes to us, patient gets a new hip, they get out of the hospital, for the most part they're taken care of. However, a patient with cancer, it's a lifelong journey for that patient with that diagnosis. So if you look at the cancer care journey, we have to think about the big picture. How can we impact that patient in their cancer journey? Because as I've said, after surgery, these patients go through adjuvant therapies, which are again chemoradiation. They have a recurrence or they have a second primary, and the cycle repeats itself. So in the big picture, when we want to make an impact to the system, to the patient in their cancer care journey, I think the important thing becomes, how can we provide optimal anesthetic care or perioperative care for the patient so they go through this journey without or with minimal complications. They can get back to their cancer care journey so we can influence long-term cancer outcomes. So in that realm, if we were to look at our role, I would say we need a 5-star approach. The first and foremost is awareness and education. Starts with the patient and the patient's family, but more importantly, us. How does cancer biology change the physiology of the patient? What effects do cancer therapies have on the physiology? And is evaluation of a patient with cancer who has undergone cancer therapies the same as any other major complex patient? The second important thing is to provide patient-centric, value-based perioperative care, particularly with a focus on early complications. Now, value-based care is not just a fashion term that's being used across the Western world because we have to contain costs. But in the cancer patient population, this is particularly relevant because we have to reduce the complications, bring the cost down, because patients with cancer who have had surgery, if they have early complications, their recurrence rates are higher. So everything we can to minimize early postoperative complications and get them back on their journey would improve long-term outcomes. And then if we were to influence that in the cancer care journey, we have to get them back on track so they can get their adjuvant therapies and they can get to their cancer care plan. Here is something very important, at least in the US. High complex cancer care is best delivered in high volume centers. And this has been repeatedly shown in esophageal, gastric, pancreatic, colorectal, and bladder surgeries. And the reason is not just for the early complications, but our ability to screen, to have the patient in proper surveillance, get them to the proper adjuvant therapies, and complete that comprehensive cancer care plan we have talked about. So in the last few minutes, what I want to do is, where do we go from here? So I hope this is the foundation for what you'll be hearing over the next 2 days. We have 3 parallel sessions. One, we're talking about all the research that's going on in the field. The second is the blood management strategies. So what Tim had said earlier, we were able to bring together basic scientists, translational researchers, and the clinicians working together and start talking about topics, ideas, interests on where we can influence cancer outcomes. It's not just about an anesthetic technique, it's about the comprehensive care plan. And the important areas where our collaborators and our friends are working on right now is, what are the effects of tumor biology on perioperative care? Why is it that some tumors have a greater propensity to cause anemia, frailty, diminished functional status, and immune functions? How do neoadjuvant therapies affect anesthetic and perioperative care? What is the effect of perioperative surgical stress on tumor burden, and how is this influencing tumor recurrence? Effects of anesthetic and perioperative care strategies on tumor biology, particularly the microenvironment, and does that play a role in early recurrence? Can patient pharmacogenomics inform which patients are going to respond appropriately to our therapies? How do our interventions influence early postoperative complications? And we've already discussed that that has a bearing on recurrence-free survival. Can we get the patients back on track early so they can go and get their adjuvant therapies? But what are the special needs and challenges of these patients when they take a turn for the worse? What are the special challenges in the critical care of these patients? All of us know the new immune therapies that are coming up. We still don't know how they impact the patient. Every day we are finding about new complications associated with immune therapies. Just last week in our own hospital, we found that 2 patients who have had immune therapies have had a Guillain-Barré-like syndrome, which was not expected, but it's the first time it's been seen. And how do we incorporate the big data? How do we bring together the data we have right from genomics, the proteomics, the metabolics, the postoperative complications, the clinical outcomes under one umbrella, so then we can study how the tumor biology and the perioperative care strategies interact to further improve our oncological outcomes. So we started this journey in 2012 with the first global meeting in Houston, and as Tim had said, since then we've conducted education sessions in one form or the other in 15 countries. And our collaborators have published quite a bit, both individually and as a group, bringing out manuscripts and books on these topics. These are some of the examples. You have this in your package. So our next meeting for the 5th anniversary will be back in Houston. So save your dates. It's going to be between November 29th and December 3rd. But more importantly, there is so much momentum and interest that we already have meetings planned out to 2022, so the next 5 years. So I would encourage you to join us in this movement. Give your ideas on how we can influence cancer outcomes, because this is not just going to be for us as clinicians, but also we will be dealing with this malady in our own personal lives with our loved ones. Thank you very much.